Sounds good. Yeah. So today we will start off with the fellows presenting the presentations they found very interesting at the AAAAI, and we also have a few slides from the faculty. But we this is meant to be an interactive session, so we invite everybody to join in and comment. And also, once we are done with the few slides we have here, if anybody in the audience would care to share interesting things they would want to talk about they learned at the Core AI, please do so. And here's just a few pictures we put together from some of our group and mostly the fellows presenting. So, all right. So this is in no. I'm just going to kind of keep advancing slides, and if you see yourself on, please talk. So, Christine, are you here? Christine is up first. If Christine is not here, we will move on to the next person. But let me see. And we can come back to it if she's not here, but I hope she will join. So let's skip on over to Jocelyn.
Hi. This is a talk I saw. It was more of a debate between two pediatricians from academic centers, one from CHOP, one from Colorado, talking about the use of live vaccines in patients who are on dupilumab. You can advance. Okay. So they just presented the idea that where this comes from. Why do we avoid live vaccines in patients on dupilumab? There is some thought that with other biologics and meds that they've studied, that live attenuated vaccines are dependent on IL-4 and IL-13 to produce titers. So there's a concern that maybe dupilumab could block this humoral response in some way, though there's no direct evidence of this. And then they cited an open label extension study of dupilumab in asthma patients. And in Brazil, there was a yellow fever outbreak, so they actually did end up giving a lot of these patients live attenuated vaccines. And the 37 patients who received the yellow fever vaccine, they measured their dupilumab levels and their seroprotection from yellow fever, and they did have seroprotection and no subtherapeutic levels of dupilumab, and no one had any sort of vaccine-related adverse events. You can go forward. Okay. So the big question was just kind of like, in the absence of data, we can't determine safety, and this leads to contraindication in the prescribing information. So down below is what is in the prescribing information currently. So avoiding the use of live vaccines during treatment with Dupixent. It's unknown if administration of live vaccines would impact the safety or effectiveness of the vaccines. And I think they were just bringing up, like, is it really right to err on the side of caution when no data exists? And I think that, a lot of how our approval for medications works, that is the case. But they brought up, like, how we consider the risk of the alternative of not giving patients live vaccines, especially currently with measles outbreaks going on. They just kind of pose the question of maybe it is safe. There's just not a lot of evidence, so they just kind of brought up that other side.
Is that it? I don't get it. I mean, since IL-4 and 13 are important for IgE responses, is the current concern here you wouldn't make an IgG response or an IgM response? Or
Yeah, I think that the data is just kind of extrapolated from other biologics, which may be actually immune suppressive, but they were arguing that because Dupixent is not actually immune suppressive, that it shouldn't. But this is the reasoning. This is the reasoning why people are concerned in general.
sounds like a straw man argument. I don't get it. So is that in the label? Is that the point, that this is a label relative contraindication that shouldn't be?
I think that's their point. Yeah, I mean, we don't have the data to say for sure it's safe, but they're arguing like when we make these blanket recommendations in the absence of data, are we considering the risk of the alternative enough?
Yeah, I would say at Roosevelt, this question has come up a few times with our eczema patients, but my understanding in current clinical practice, we generally wait those 4 weeks in terms of live vaccines. Yeah.
They're not concerned that this is an infection risk, right? That you're giving them a live vaccine and that's a risk you're going to give them a systemic infection. It's that they won't make an adequate immune response.
Yeah, it's that they wouldn't make an immune response or it would somehow affect the treatment, or they don't know if it is, quote, safe.
Okay.
Yeah.
All right. It is what it is.
Thanks.
Yeah. Good. What's next?
Next. Okay, so Patricia.
Hi there. I was just gonna summarize a few points from different talks surrounding asthma, just to have a unifying theme here for my slide. So I'll just go in order of panel. So in the first panel on the top, it's from a review that really just gets to the different contributors to asthma and the clinical symptoms we see and the progression over time. So these things include genetics, the microbiome, which we, in terms of loss of personal microbial diversity that we talked about previously, environment, such as exposure to allergens, smoke, treatment in terms of what we're seeing from in response to viruses and the types of treatments that are effective versus not. And part of that talk was to sort of hammer down the point that early life viral infection, particularly RSV in the first year of life, based on birth cohorts, such as the COAST cohort that they've been able to follow over time, showed that there was an increased risk of developing actually non-atopic asthma and non-atopic asthma as defined by presence of other atopic disease like eczema, allergic rhinitis, et cetera, by age 6 that seemed to be sustained through age 11. There's actually some mixed data in terms of the risk of RSV and later in other cohorts. It's just an Australian cohort and a Finnish cohort, but this was seen in one of the cohorts done in the US. To get at another component of that diagram above in terms of genetics, there was a meta-analysis presented of GWAS studies where there were 18 genetic loci that were associated with asthma. But through their statistical analyses and doing some causal mediation analyses, they showed that these loci only explained only 3 to 5% of disease risk. I think this really emphasizes the need to study other influencing factors of asthma, including the environment, epigenetics, et cetera. Switching gears a little to this middle panel, this was a study that was published in JAMA 2025, so not very long ago, that they were trying to, this gets to sort of the different endotypes in asthma, T2 high, T2 low, Th17 high, and how we can potentially start to feasibly incorporate this into the clinical setting. So this is how they're proposing this, of course, early in the studies, but they're doing nasal transcriptomics on it. So a swab of the nasal passages rather than a bronch, which is obviously not possible in many children and probably only feasible in adults with other concurrent respiratory disease. So they took a swab, put it in the child's nose, similar to sort of a COVID swab before. And they, based on previous literature in asthma, used signatures that were typical of a T2 high. So that's the top panel, the POS, so periostin, POSTN, SERPIN2B, and CLK1. These are typically high in Th2 asthma based on lower airway literature from before. And to sort of the bottom half of the heat map is Th17 typical genes, again, based on lower airway. And they showed that when they took different cohorts that are sort of established with data that is available, that you can, that by using clustering analyses, you can use the nasal epithelium to cluster these patients, or rather these samples, to T2 high, T2 low, T17 high, or T2 low and T17 low. The top and the bottom panels, they're just different cohorts, just to show that it's able to be repeated. But I thought it was interesting in terms of actually a feasible way to profile patients more effectively in terms of the concept of precision asthma treatment. Of course, it's not validated at this point, and the predictive value of it, they mainly looked at how well does the T2 high correspond to the eosinophils, the blood eosinophils, and it was quite correlating, but obviously not perfect. So I think just something in development, but interesting nonetheless in terms of being able to actually do precision medicine from a respiratory sample rather than what we're doing now in the serum, which may not always be representative. The third panel, again, gets to these different endotypes, looking at how there's actually a crossover between T2 and T1 inflammation. I thought that was interesting because I feel like when discussing the different endotypes and phenotypes in asthma, we sort of group them into different separate buckets, T2 high, T1 high, non-T2, these kind of things. And I thought this was an interesting presentation in that there, certainly are folks that don't fall in any bucket in terms of being low in multiple respects. So the lower left part of the diagram there, where they're T1 and T2 low, and here they're typically polygranulocytic with low pheno, often steroid resistant and non-responsive to T2 biologics. But I feel like some things that are, at least I had less awareness of, was the crossover between the two, where you can have both types of inflammation. So T2 and T1 in this case, high asthma, which correlates to sort of worse obstruction, more severe asthma, worse outcomes, and more difficulty in terms of the treatment, where you have this mixed inflammation. You do have a high pheno suggestive of eosinophilic asthma, but they're steroid resistant, and there's only a partial response. So I think something to think about in terms of if patients are responding to TH2 targeted therapies, but aren't quite improving to the degree that they'd want in terms of symptom management and quality of life. And then the last panel was just another piece of another diagram that was presented that I didn't know much about, but that sort of know there's different flavors of T cells. We know there's different flavors of macrophages, but I've never really heard someone present different flavors of eosinophils before. So they were discussing this concept of an inflammatory eosinophil that has these specific markers that are pictured there that corresponds to a T2 immune response, and sort of resident tissue eosinophils that are more immunomodulatory and potentially could contribute to non-T2 response. But that's all I have.
What talk did this come from, this one image?
The eosinophil one?
No, did you put this together, or was this slide?
I put this together. So these are multiple images from a group of talks on Friday. I think it was T2 and non-T2 asthma. The presenters were Jim Gurn, Sally Wenzel, and Anurada Ray were the images these were taken from.
Is there a therapeutic take-home message?
I think for this, I think in terms of what is in the therapeutics right now, I don't think there is. I think this is all sort of research that is getting to what can be a way to develop more precision medicine down the line, and why are people sort of only partially responding to certain treatments.
Okay, thanks.
I'm going, Christine, I believe, is on, so I'm going to go back and have her share her slides. There we go. Christine, are you Are you here now?
Yeah, for sure.
Thank you.
Sorry for that. I was having trouble with the link for whatever reason. Sorry. Basically there was just two talks that I was going to briefly go over. The first is a talk from the Discovery Day by Alex Larson that was looking at some of the new uses of CRISPR. And then the other one is just a quick update on primary immune deficiency, kind of as a whole. Probably one of the better talks that I went to over the course of the session. So Alex Larson is a professor at UCSF, and his lab studies basically how to like improve CAR T cells. So basically just, they study it in many different contexts. Obviously, we medically use T cell therapies for cancer treatment the most. And I did not actually know this, but apparently these treatments are actually limited by suppressive signals that can come from either extrinsic or intrinsic factors within the body, the intrinsic ones being sort of like inhibitory checkpoints. And he was looking at whether or not you could use targeted gene editing to try to overcome some of these intrinsic inhibitory checkpoints. So basically, he sent a few of papers, but I thought the one that was maybe most relevant from an allergy perspective is that he did do this like genome-wide CRISPR knockout screen and expose the cells to different immunosuppressive conditions to try to select phenotypes of interest. So in this particular case, he's trying to find cells that will proliferate despite exposure to cells either coming from drugs or from Treg cells. He ended up identifying this protein called RASA2, which is downregulated upon TCR stimulation, and basically showed that ablation of this gene enhanced cytokine production, T cell activation, and then basically led to the enhanced persistence of cells and increased effector function of the T cell therapies in the setting of cancer treatment. So I think, I thought this was interesting just because it sort of shows that even though CAR T cells have been really game changing, there is still a lot of room to optimize these therapies. And, in the setting of, immunology, right, our patients have a lot of autoimmune diseases. People have been looking at using these CAR T cells to try to induce long-lasting B cell depletion, in which case, things like this, where you can actually have longer survival of some of these CAR T cells, can be really helpful. CAR T cells are good asthma. They're also being engineered against infection. And given that a lot of patients with inborn errors of immunity have, very chronic infections, again, I thought this could all be very relevant to our population. So that is why I went over this talk. And then the other talk these are just kind of like summary notes from a talk by Yasmin Khan that was just broadly giving updates in PID. Basically in 2024, there was an additional 50 diseases identified, although most are phenocopies, which in the setting were defined as being caused by a somatic mutation or an autoantibody against against various cytokines. And just as a review for most of us, these cannot be picked up on standard genetic testing. I thought this was interesting. So that current estimates are that we detect only about 30% of inborn errors of immunity, and that most of the remainder 70% are thought to be phenocopies. And I think, our tools to try to identify phenocopies, I think right now are pretty limited in the sense of we can go after what we know with autoantibodies, or we can use deeper sequencing to try to pick up somatic mutations, but that's not always routinely done. So it sort of suggested that we really need more technological development in order to be able to make progress on this front. In terms of getting at the genetic approaches themselves, things that needed to be done would be to adjust for the low allele frequency. People are starting to look at single cell sequencing. It's also important to note that when you do all of this, there can be mosaicism, and that could be in either the somatic or the germ cell populations. And then this, I think, was just kind of called out over the course of the talk that if this is something that's on your differential, there is a mosaicism panel that can be ordered from WashU that targets genes that are commonly found in mosaicism. And then the next sort of subtopic was when to, pursue these types of approaches. So, I think the one that we commonly use is, new clinical symptoms at an older age, especially when it mimics a known inborn error of immunity. The one that I think I wish I went into a little bit more detail about was when to do it in the setting of immune dysregulation and negative genetic tests. Just in part because, immune dysregulation and negative genetic tests also sort of describes every rheumatologic patient. So, it would be nice to have, data or algorithms that can sort of break down who of those are, higher risk versus who of those are lower risk. Obviously, the two factors below being informative as to that. And then I guess, I just sort of listed like some of the examples that they went over of inborn errors of immunity with known phenocopies, just to remember, phenotypes to keep an eye out for. And then I guess I didn't actually know this, there are actually apparently some somatic disorders that do not have a germline equivalent, like UBA1, which is vexus. That phenotype pretty much only exists in the setting of a somatic disorder. PIK3CD as a germline mutation has, a very classic phenotype, but then in the setting of a somatic disorder only causes lymphatic malformation instead. So I think it's also just important to remember that these genes can, mutations in these genes can manifest in various different ways, which, and that range of phenotypes is expanded when you consider both germline and somatic mutations. So yeah, that was what I had to go over.
I don't pretend to understand the genetics here, but does this mean that we're missing 70% of cases, or 70% of people present clinically with an inborn error of immunity are not explained by the standard genetic approach?
So like, I guess yes and no. So, these are obviously epidemiologic estimates, and I think that there is, error margins on all of this. But I think you kind of got the main point correct, which is that we are only finding a small percentage of all of the inborn errors of immunity out there. And most of the ones that we are missing are phenocopies, and a lot of the phenocopies are somatic mutations or are autoantibodies. And we basically need better technology to try to detect somatic mutations and autoantibodies. We have sort of like known diseases, right? Like when you've got an antibody against interferon gamma, and that can mimic MSMD. But the thought was that there's actually a much broader range of autoantibodies and that we can't always find them.
So it's not that we're missing these cases, is that people come in with what looks like a certain given inborn error of immunity, but they don't have the unique gene that we attribute to that. They have some other mechanism.
Correct. I think this data was supposed to be, about the patients that we do studies on, rather than like, oh, we're missing, patients that don't come in.
Yeah, okay, I get it.
Thank you, Christine. That was great. I'm going to stop share right now. Hannah, another one of our fellows, will share her slides. So bear with us for a moment. Hannah, can you go ahead and show your slides?
Yes, thank you. Sorry to make this tricky for everyone.
Of course.
Let me just. Okay, can everybody see this?
It's very small.
Is it? Okay, let me.
Yeah, showing your like the you in one video and then the
Oh, I don't know why
PowerPoint
it
video.
does that.
It's big enough to be readable, but it's about 1/8 of the screen, at least on my screen.
That's here, I have a better idea.
Unfortunately, it still looks like you're having a dual screen presentation.
All right, Hannah, why don't you email me those and I will share them at the end of the
Wait,
presentation?
is this better?
No, it's, oh, okay, now it works.
That's
Okay.
good.
Okay, thanks, guys. So I went to the Outmatch trial session looking at omalizumab versus multiple allergen oral immunotherapy in the treatment of multiple food allergies. And this was a pretty big session. It was really interesting. It was the second phase of a pretty big trial, and I'm guessing you guys are all super familiar with it. And I think a lot of people also went to this session. So I'll just kind of give briefly what I learned. So this study was, so it was kind of an interesting setup, and I'm wondering if I have it in here. Nope. So it started off, the study started off by giving everybody omalizumab, and then it added in placebo oral immunotherapy or actual oral immunotherapy, and then it swapped in the true oral immunotherapy, it swapped the omalizumab to placebo omalizumab. So I thought it was kind of an interesting setup. But the main point is that when at the end of the study, so 36% of study participants who received the extended course of omalizumab could tolerate 2 grams or more of peanut protein, or about 8 peanuts, and 2 other food allergens by the end of the treatment period, but only 19% of patients who received the multiple food oral immunotherapy and the placebo omalizumab could do so. The really interesting thing about this study was that this was using the intention to treat. And when they actually did the per protocol, they found that there was no significant difference. So that's why they were attributing this difference primarily to the high rates of allergic reactions and other intolerable side effects among the participants who received oral immunotherapy, leading a quarter of them to discontinue the treatment. So, oh yeah, here is where it goes. Okay, so there were 117 participants who were included. And then I kind of already went over this. There were a number of serious adverse events. So these are photos I took from the Quad AI of the slides. I don't know if I'm allowed to share these. Is this getting shared to YouTube like our typical? Does anyone know? Okay, well, I'm just gonna share them then. If there's
You can go ahead and share them.
Why don't you think you can share them?
so they're photos from the Quad AI. Am I allowed to share these?
Yeah, I don't see why not. It's a public meeting.
Okay, perfect. And they'll
Yeah.
be published online for all of us to access. But so these were the adverse events. So I thought it was so I think like part of the biggest reason that people withdrew was anaphylaxis, and you'll see that 27% of the patients who did multiple oral immunotherapy met criteria for anaphylaxis. Interestingly enough, actually 2% or 1 participant on the omalizumab and placebo oral immunotherapy also met criteria. But while 22% or 13 of the participants met or had adverse events resulting in withdrawal, 0 participants or 0% of patients had an adverse event that led to withdrawal. So like I mentioned earlier, a quarter of the patients on multiple oral immunotherapies had to withdraw from the study, but none of the patients on omalizumab had to withdraw from the study. So I thought this was really interesting because I think, and they were kind of talking about this in the meeting, my understanding of it at least, is that maybe less so that it was the actual physiology of the way these are working, and more so just the tolerability of the therapeutic treatment. And then this was just one other slide that I thought was really interesting. So these are looking at the success for individual foods at each cumulative tolerated dose. This is the intention to treat protocol or analysis. So you'll see for peanuts, the orange line is the omalizumab and the blue line is the multiple food oral immunotherapy. So you can see that it did a really, really good job for peanut, but less so for the other specific foods. And particularly when it comes to wheat and hazelnut, there really wasn't a big difference. Then again, when you look like the wheat and the hazelnut, it was a far smaller N, whereas the peanut had the biggest N. So from a power perspective, you know, maybe that was just because they didn't have enough participants where they were looking at those particular foods. But I did think this was interesting as well, just from thinking about counseling your patients depending on like what types of food they have. And I think it'll be interesting as more and more work comes out on this. And then lastly, these were just some random facts that I collected from the meeting that I thought were really interesting. So I went to kind of a panel type of situation where they were talking about using biologics in pediatric patients. And I thought it was a really good discussion. And one thing that I thought was that I wrote down was that if you are having trouble getting Dupixent covered by insurance, now I have never tried to get personally Dupixent covered by insurance, so maybe you guys have never had problems with this, but several of the providers in this panel had. And those of the providers that had had a lot of luck with this found that using eczema of the hands and feet as a diagnosis to gain approval had never had any issues, and that was their go-to diagnosis they used in order to have this approved. Then there was a live discussion on pre-Dupixent initiation testing, and this was a question that I kind of just had. Now, this was again on the pediatric side, but I was honestly curious, you know, if you guys had ever thought about this. And this was for asthma. So everyone agreed CBC with diff and IgE, but then there were kind of two camps of, do we get pheno testing before versus after? So I just thought that was interesting, and I was going to look more into that. And then there was a study that they presented on looking at the efficacy and safety of house dust mite slit tablets, particularly in children, in treating house dust mite sensitization and like allergic rhinitis. And they found that it was basically relatively equivocal in efficacy and safety in children, adolescents, and adults. Again, you guys, I don't think most of the people in here treat a lot of adults, although I did see Taylor in here, so maybe this will be helpful to you as you guys move forward with creating your, setting up your entire allergy side of things on the pediatric side, but just knowing that that is something that can be used. I don't think it is as widely used currently. And then the last fun fact, I guess, that I have is that I went to a session on anaphylaxis, and this is a study, it was a presentation on a study from Montreal that it's basically, they have this really cool thing. I think maybe we have it here too, but at least I learned in Montreal, they have this thing called the anaphylaxis registry, where when anyone who comes in to the hospital with anaphylaxis, they will gather information on them. So they'll look at like, what do they do beforehand and where do they go afterwards? And this study is actually, I think it's a continuation of a study that was, it's the same study group that in 2019 did a study and found that looking at like basically epinephrine use pre-hospitalization or pre-ED. And the study this time found that using epinephrine prior to the ED decreased the risk of an ICU admission, and that outpatient antihistamine use did not change the rate of ICU admission. I quoted the 2019 study because their 2019 study, I went back and looked, and it found that using antihistamine with epinephrine can help symptom management. I looked at that very briefly, so don't super quote me on that. I felt like this was pretty it makes a lot of sense to me. I felt like it was kind of common sense in a way, but I think when they were giving the study, I think their point was that at least in Montreal, epinephrine use can be or underused prior to the ED. Like a lot of patients aren't self-administering it. So I thought this could be an interesting study to quote in talking to your patients about, why it's important to use epinephrine if you are truly concerned about anaphylaxis. Just one point of data. And that is everything that I had.
I'm just curious about the third point, the efficacy of house dust slit. I don't think house dust slick works terribly well in anybody. But did they actually have data? Must have.
They must have. And this was one of the ones that I kind of just took a photo of the last slide because I thought it was interesting and it was on my list of things to look up later. So I don't have the data that they actually talked about to support this statement, but it will be coming out in 4 to 6 weeks.
Anybody want to comment on that? Have people used it much? I mean, it works in grass for sure. I don't know how well it works in dust mite. I'm sure there's studies that show it worked or it wouldn't have gotten approved, but there's a difference between studies and real world therapy.
Yeah, I think it's hard to tell from our individual experiences. Like, I think we all have some patients on it. I feel like I don't have enough to make any conclusions from my own patients. So yeah, I'll be curious to see the study. Great. Hannah, would you mind stop sharing the screen so we can? Thank you so much. And I think Jenny, you're on.
All right, everyone, can you hear see my screen and hear me?
Yes.
Okay, wonderful. So we just went to full screen. So takeaways that I'm presenting on today is from the NIA difficult cases, where essentially a junior faculty is paired up with senior faculty mentor to discuss patient cases and give some pearls of wisdom. Just a shout out, nominations for next year's cases are currently underway, both for senior mentors and for junior faculty members. So if anyone's interested in participating next year, I thought it was a really great experience as a junior faculty member. And here's the link to sign up. It's actually quite a few nominations underway already. All right, so what I'm presenting on is the challenges in oral immunotherapy, and there are actually quite a few studies and tools for shared decision making, which I thought would be really interesting. Credits to these slides go to Dr. Scott Schisser from Mount Sinai. So kind of a nice supplement to Hannah's presentation in terms of the outmatch study, original study, who would be favoring treatment versus not favoring treatment in terms of use of omalizumab. So kind of a compare and contrast, which is helpful for shared decision making. So for patient scenarios that would not favor treatment, for transient food allergy potential or patients who are very successful at avoidance of their food allergens, or necessarily have a higher reaction threshold for those who have some tolerance of accidental exposure that doesn't necessarily give them particularly threatening symptoms, or people who are already successful on oral immunotherapy without supplementation from omalizumab, versus patient scenarios that would favor treatment with omalizumab, multiple food allergies, difficulty with avoidance, severe reactions, even with minute amounts of accidental exposure, chronic gastrointestinal symptoms or contraindications to oral immunotherapy, and of course, significant anxiety or quality of life burden with pre-existing food allergy. We also talked about in terms of oral immunotherapy, in terms of consensus, what are some absolute and relative contraindications for oral immunotherapy? And I thought this was really interesting. Kind of my thoughts about oral immunotherapy is that certainly it, unfortunately, is something that favors patient families that are well-resourced, that can have the time to initiate treatment, have good, reliable access to transportation. So those are all things I think about quite frequently when I decide whether or not a family should start oral immunotherapy. So what surprised me about this is that actually the number one absolute contraindication was unwillingness to use epinephrine in case of adverse reaction. So I thought that was quite interesting. Uncontrolled asthma, pregnancy, I think that makes sense. We also think about this with subcutaneous aeroallergen immunotherapy and so on and so forth. There's also essentially a decision aid for food allergen oral immunotherapy in children, essentially going through certain criteria and decision of whether or not to start oral immunotherapy, food allergy burden, how likely patient families are able to practice avoidance, and how does the choice of adding oral immunotherapy align with the patient values, affect their quality of life, and whether there's enough support to successfully implement oral immunotherapy for the family. And last little bit from Dr. Shizer is about oral immunotherapy and EOE, and I found this very interesting as well. Kind of what I have previously practiced is that ultimately pre-existent diagnosis of eosinophilic esophagitis or start the process of eosinophilic esophagitis during the treatment process for oral immunotherapy essentially is an absolute contraindication. We stop the oral immunotherapy. But I think it turns out it's a little bit more nuanced than that. And there can be cases for continuing oral immunotherapy even with EOE. It is controversial and definitely needs quite a bit of shared decision-making, talking through what the risk versus benefits are, but not necessarily an absolute contraindication. And of course, if there is suspicion of EOE during oral immunotherapy, GI evaluation is recommended. And also, like Hannah, I did include a slide just kind of other random pearls that kind of stuck out through me from both the NIA difficult cases and the hot topics in pediatric allergy and immunology, and things that came up for pregnancy and asthma. I was trained on the rules of 30% of patients with asthma who are pregnant get better, 30% get worse, 30% stay the same. But it turns out it's not so. More recent studies show that roughly asthma is stable in 70% of patients and worse in about 40% of patients during pregnancy. In cases of delayed onset urticaria, so after that roughly 48-hour threshold, there has been studies showing that going straight to amoxicillin graded challenge without preceding testing is safe. And last but not least, there has been a dose-dependent association between exposure to secondhand smoke in the environment and development of eczema in children, as in children who have two parents who smoke are more likely to develop eczema compared to children with one parent. As we know, in terms of that association versus causation, dose dependency does potentially support causation. So I think eczema is very complicated, and I don't know if we'll ever have very straightforward answers on what is causing eczema and not, but I think this was very interesting. So yeah, I think those are all my slides. Thank you.
So in asthma, we have 110% of women, 70 and 40.
Oh, geez. Sorry, I think it's 70-30. Thanks
Yeah.
for the catch.
I don't know about the rest of you. I don't do that much with food allergy, but it seems to me sort of a no-brainer that omalizumab is so much more effective and less significant side effects, that comparing it to oral immunotherapy, which is fraught with all kinds of problems, that's again somewhat of a straw man argument to compare the two. I don't know, for those of you who do a lot with food allergy, any comments on that?
This is Neetu Talreja. I'm listening from Boise, Idaho, and I've been doing oral immunotherapy for kids for the last 5 years in my facility. I've never had to use omalizumab, and I really would say that it's a very safe process. I was not very convinced with the data from the outmatch stage 2 that they presented. We have almost had 150 kids that we have done OIT, proving that they're really they are sensitive, they are allergic through oral challenges. And have done oral immunotherapy, followed the protocols, and these kids have done with reduced IgE. We challenge them annually to 3 times the maintenance dose and have never had to use Xolair so far. Some kids do develop ELORs, which the EOE, that complication that one of the fellows mentioned. And yeah, it is a shared decision making, but really we still maintain it. We reduce the dose to 1/4 and then slowly get them back to like follow them closely and just do very slow dose progression. So I would really invite your fellows, if they ever want to come to Boise and learn about OIT. I really do not think that omalizumab is needed. And its OIT is super safe if done, correctly, how uncontrolled asthma is a contraindication. I think we haven't had to use epi more than twice in the last 5 years that we have been doing. So the willingness to use epinephrine, yeah, of course, we do talk to them and we would like them to be comfortable using epi, but really it has been super safe for us. And the data from published by Dr. Wasserman, Dr. Wyndham for the centers for 25,000 patients last year that the whole country did has been very, very impressive. So I would encourage all of you to look at the data presented. We do have a OIT list serve of all the people who practice OIT in the country, and they share their experiences, and you would see that practically none of them talk about using Xolair to desensitize their food allergy patients. So I don't want to take time of the rest of the staff faculty here, but yeah, I would welcome for you guys to sometime attend one of their meetings. Their meeting is in June for food allergy support team OIT, and it's totally OIT based meeting where all the practicing OIT physicians get together and present their data. Very impressive.
Well, thank you for that perspective. That's all. I didn't know you were doing that so extensively. Totally a different perspective than what I said, but I'm not practicing this. Looks like Gabe also has data on this issue.
Yeah,
Yep,
so I'll
Gabe.
be quick about it. Hannah already did a great job at presenting. And yeah, I happy to hear everyone's remarks regarding OIT so we can learn together. So I could contribute by just reviewing a little bit the ALMATCH stage 1, which was presented the year before, but it was briefly reviewed during the talk. And so there's a typo there where it says only 1 adult, actually only 3 adults were included in the ALMATCH study, and it's predominantly children and adolescents, the median age being 7 years, and there was 177 participants. And then these are specifically participants that are allergic to peanuts and to other protocol-specific foods, which they chose as cashew, walnut, hazelnut, egg, milk, and wheat, or wheat. The primary endpoint was ingestion of at least 600 milligrams of peanut protein without dose-limiting symptoms, which they defined as any symptoms that they felt were too severe to continue on with the oral food challenge, or if there were multiple mild symptoms, then they would stop the oral food challenge. The key secondary endpoints included at least 1,000 milligrams of cashew milk or egg protein. It's interesting that they picked 1,000 because, for example, with cashew, as you can see on the right, it probably ended up resulting in their numbers being lower because that cashew actually ended up being one of the allergens that seemed to be more potent for patients and that they responded at a lower dose. And I think actually even as little as 10 milligrams for a lot of the patients. But in general, omalizumab was found to be superior to placebo, increasing the reaction threshold for peanut in all the foods. So, like I said, you could find this at the New England Journal of Medicine publication, but you could see pretty clearly 67% compared to 7% for placebo. So there's still that 33% of patients that are not responding to omalizumab. So that is important to know in terms of their primary threshold of 600 milligrams of peanut. And then for the secondary threshold, it's 41% for cashew versus 3% placebo, 67% egg, 0% placebo, 66% milk, 10% compared to placebo. So that's the review of the AMH stage 1, and then I focused on stage 2 as well. No, you can move on to the next slide. So this is what Hannah already presented. So just to quickly review, this was those same participants that were in stage 1. 117 of those moved on to stage 2, which once again was looking at comparing OIT and omalizumab. So yeah, it was multi-center randomized double-blind placebo trial. So once again, it's multi-allergen OIT. So they were allergic to peanuts and at least 2 other foods. And then they would get a placebo omalizumab, or they would get omalizumab and then placebo OIT. But it's a little bit of a confusing protocol because it's not quite that necessarily, because all participants received omalizumab from week 0 to 16. So then after that, on week 9, that was when OIT placebo or placebo OIT was initiated and was escalated to a maintenance goal of 1,000 milligrams if it was the actual OIT for the specific foods for that participant. And then week 16, like I said, was when they introduced the placebo omalizumab, or the actual omalizumab. So they reintroduced omalizumab, or they introduced a placebo at week 16. So all patients had some baseline omalizumab in their system, at least for 16 weeks prior to the initiation of OIT for those patients that started on that. And then at week 44 was when they re-challenged patients to foods, a cumulative dose of 8,444 milligrams of protein. And then the protocol-defined primary endpoint was a tolerance of at least 2,000 milligrams, a cumulative amount of 4,044 milligrams. So pretty aggressive primary endpoint. Compare that to Palforzia, which is FDA-approved OIT for peanut. That's only 300 milligrams, which is 1 peanut. So this is 7 times, approximately 7 times that amount. So then the next slide. So then, yeah, the results, once again, yeah, 117 participants, 55% male, 7 years was the median age. So as you can see, you have about 88% of the melasma group and 51% of the OIT group completed the stage. So that's where the differences in the results come from. Just about half of the OIT group just didn't finish the protocol. They didn't, because of adverse effects mainly, which is the last bullet point. So when you look at the intent to treat analysis, it shows that omalizumab was superior to OIT. It's 36% versus 19%. Once again, relatively low success rate for both, given the high amount of protein as a primary endpoint. But there were no differences when you looked at the per protocol analysis, which excludes the dropouts that were in the OIT group. But generally, with these type of trials, you do look at the intent to treat analysis, because there could be bias that's introduced if you look at the per protocol analysis. And if you just look at pro protocol analysis and excluding the dropouts, then it sort of biases your sample, and randomization is no longer really in effect. So that's why you do have to look at the intent to treat analysis overall. But the point being that if folks maybe hadn't dropped out, then the efficacy of both groups would have been very similar. As you can see, serious adverse events were 30.5% compared to 0% for omalizumab only. And then adverse events leading to treatment discontinuation, 22 versus 0. And then adverse events leading to epinephrine use, 37.3% compared to 6.9%. So overall, omalizumab seems to be very safe. So you could go to the last slide, Anya. So conclusion, omalizumab was superior to multi-allergen OIT treatment of multi-food allergy. If you look at the intent to treat analysis, differences in outcomes are largely driven by the high rate of adverse events in the OIT treated participants, which led to the study discontinuation for those participants. And like I said, adverse events occurred for the OIT treated participants, despite them receiving omalizumab at the beginning. So they had some baseline protection from omalizumab, but it wasn't enough to help them not have as many adverse events from the OIT protocol. So something to take from this is maybe patients would benefit in general from being omalizumab with OIT as one, and that just kind of giving the risks and benefits to patients about whether they want to be an OIT as well, in addition to omalizumab. I didn't go through stage 3 of the outmatch study because I didn't make it for part of that talk. It was the earlier part of the session, but that was looking at just omalizumab and giving patients the opportunity to ingest food as OIT or actually just ingest food openly without any limitations. And in general, it seems like there is some longstanding protection for patients if they use omalizumab even after 12 months of not being on it. There was portions of patients that still tolerated about 300 milligrams of different foods, peanut and all the other foods that I mentioned. So there seems to be some potential long-standing baseline protection that patients may get, or it might be that initially omalizumab helps them eat the food and they're able to develop some tolerance to the food, and then may not have to be on it long term if the goal isn't to eat a full serving of the food.
Abe, is there any reason to think that if you stop giving omalizumab at week 16, that it has any effect still at week 44? Did they measure, for example, free IgE levels to see if they were? It wouldn't make any sense to me that they would still be suppressed all that time later.
They didn't touch on that here in this outmatch study, so I think there actually might have been a different abstract looking at that type of data, but I didn't look at that. Specifically, I wasn't presented during the session. So I'm not sure about that. Yeah, it is interesting that does seem to be some longstanding protection. And it might be, like I said, if folks are eating the food while they're on omalizumab, their immune system is developing potentially some tolerance to that food allergen, especially if you start this young, right? At really young ages, the immune system is still developing. It's very plastic. So there maybe that's that patients are using, omalizumab can help bridge patients to tolerating some food, and then maybe after discontinuation, they're able to tolerate some food because of being exposed to that food for a certain period of time.
That seems more logical than there could be any continuing effect from omalizumab that was stopped, many months earlier.
Right. Yeah, because that's what stage 3 was looking at. Stage 2 found that even with those patients that were on omalizumab for 16 weeks, they still had significant adverse events when they were on OIT, and that's why the OIT group was inferior to the omalizumab only group.
All right, thanks, Gabe. So we are almost at time. We have a couple more slides. If people are available to still stick around, please do, but we may not finish all the presentations. Kelly, are you still able to tell us about your slides?
Yeah, I can go. I just have the one, so I can do it pretty quickly. Good morning, everybody. I'll just do this super quickly. I went to a session on emerging issues in women's health, and there were just 2 presentations that I wanted to highlight. This first one was penicillin delabeling during pregnancy, a call to action by Anna Wolfson at Mass General. And it was actually reviewing some similar data to the talk I had given a few weeks ago about penicillin allergy in pregnancy, just really reiterating the safety of doing this. It's interesting because, she had gone through some of the similar data looking at different ways that people do this, whether it's starting with skin testing or going to direct oral challenge. But looking at both ways of testing, like the takeaway point was, over 90% of people are passing in these scenarios. Something else that she had discussed was that there really is not a big reason to test in second versus third trimester. Really, the biggest barrier is getting people to clinic. So whenever people are willing to come, that's great. She was part of a study that I had gone through in my talk a couple of weeks ago where they had observed, they were doing a retrospective chart review, and they had observed that there was a huge amount of patients that dropped off from the number of patients that were referred to the number of patients that were able to actually go to clinic. And so for that reason, at her institution, they have mid-levels and some of the midwives do a huge amount of the history taking. They have some curated questions, and then they're sent over to clinic, and patients are tested that same day as their appointment. So they found that helped with some of the dropout, that there wasn't this lag between initial appointment and then testing. So the big takeaway was to delabel pregnant patients unless they have a very severe history of something like a severe cutaneous, severe delayed cutaneous reaction, or, it would be a risk-benefit discussion with something like anaphylaxis. And then the second study, or the second talk, was about, this was by Vanessa Murphy, coming out of New Zealand, about the safety of asthma biologics during pregnancy, an international perspective. And so she had reviewed a couple of different studies where the bottom line was that, unfortunately, there are ongoing studies, but at this point in time, we don't have great information about the safety profile of biologics during pregnancy. There's not data at this time to suggest necessarily that it's that there are harmful effects to the fetus when used during pregnancy and breastfeeding. But again, this is based on like case reports and really limited data. She did also highlight, which I hadn't realized, that there was recently an international modified Delphi study, which was looking at the opinion of 141, quote, experts in severe asthma from around the world. And they went through a survey of a series of consensus statements about biologic use during pregnancy. And it's very, an interesting thing to look at. I think, like, as many audience members pointed out, this is somewhat limited in what it can tell us. Is this is just people's opinions. It's not necessarily based on data. But the takeaway from this study was that they had really emphasized that the use of biologics during pregnancy versus untreated severe asthma, is absolutely an option that should be considered, but really emphasize this element of shared decision making between patient and provider, and making sure that the patient really does understand that we have very limited data about the safety of biologics, but with a recognition that not treating, not using these medications when somebody is frequently having exacerbations on oral steroids can be very, very harmful as well. So yeah, those were the takeaways from those two talks.
Thank you, Kelly. I think we still have, let's see, Lily, are you still here?
Yeah, if you advance to the next slide, I can do this very quickly. So this was in the International Approaches to Drug Allergy Today session. And this was presented by Allison Ramsey, who's working with some of the radiologists to create a joint statement from ACR and from the allergy professional societies regarding guidance for management of patients with prior hypersensitivity reactions to radio contrast media. And so on the right side, you can see they kind of more clearly spell out like reactions that might be considered either side effects or adverse reactions, or just not anything to worry about, and kind of algorithm. On the left side that I put the box around are kind of the risk stratification for varying severity of immediate reactions and kind of what to do. I think there's a lot of variation in clinical practice regarding what people do from hospital to hospital. So I think the publication is under review currently in JACI in Practice and in the radiology journals. And when this comes out, I think it'll offer some guidance for people to do some more standardized management for these patients. So you can refer to this or watch the actual seminar when the recordings come out.
Thank you, Lily. Let's see next. I think just very quickly for a couple of my slides. This is from a session on chronic spontaneous urticaria treatment, kind of novel therapies. And this was a nice summary slide from Dr. Saini from Johns Hopkins, kind of highlighting the different pathways. So my takeaway from this was really that there are a number of studies, clinical studies in progress. And really soon we will be probably more commonly using treatments other than Xolair or cyclosporin for refractory urticaria. So of note, for the IgE and activating receptors targeting pathway, there's a number of clinical trials showing promising results of use of BTK inhibitors. And there's also a trial of targeting the MRGPRX2 receptor, which can cause like a non-specific triggers can lead to mast cell degranulation and hives. Otherwise, if targeting the mast cell differentiation and survival, anti-KIT medications are showing promising results in being effective in treating CSU. And finally, inhibitory receptors and Th2 immune response targeting pathways. So dupilumab is helpful in some patients, while some other targets listed here have failed or so far are not showing great promise in clinical trials. So this is super brief, but it'll be a good session to like rewatch afterwards. And then he also showed this summary of negative biopredictors by therapies. So for Xolair, low IgE below 40, also low basophil Fc epsilon receptor 1 staining. I think notably for dupilumab, the results were not predicted, the outcomes were not predicted by IgE. So they studied patients with IgE either below or above 100, and results were the same. Another thing that were highlighted in a couple of studies, that dupilumab, while it can be helpful for patients, it is more likely to be helpful it's less likely to have improvement in patients who've already been on Xolair. They weren't compared side to side, but it looks like it can be helpful, but it's not necessarily always helpful in those who failed Xolair. And then just highlight the next session the next talk in that session was Dr. Bernstein, and I will not go through this, but he provided a lot more details of what the clinical trials are for all these medications, including for monoclonal antibodies and for the small molecules like BTK inhibitors and JAK inhibitors and the MRGPRX2 blocker. So that's that. And I think we will have one more presentation that Stacy could share for those who are still here. Stacy, are you still able to do that?
I am here, Anya. I don't know if we need to make everyone stay. It's already 10 past the hour at this point.
Okay.
If anybody really wants to hear about it, I did have a little, slide on the updates in the immunotherapy practice parameters that are going to be coming out, but those are going to be visible to all of us. So I think if anyone just wants to go and start their clinic day, anyone can reach out to me if they wanted those slides, and I'm happy to chat. Unless anybody wants to really hear right now, I'm happy to show them, but it's, 8:10.
Sorry to wrap up. So, okay, thank you very much. Any last comments about the Quad AI or anything from there?
I think next week is in person.